I'm Dr. Lokeshwari. I'm here to present a topic on pathophysiology of hemolytic anemia. The specific learning objectives of this particular topic is define and classify hemolytic anemia, describe the pathogenesis and clinical features and hematological indices of hemolytic anemia. The definition: anemias which is resulting from an increase in rate of red cell destruction. The destruction can happen within the blood vessels, which is intravascular, within the spleen, and which is extravascular. What are the general features of hemolytic anemia? A shortened red cell lifespan below a normal of 120 days. Elevated erythropoietin levels and a compensatory increase in erythropoiesis. Accumulation of hemoglobin degradation products that are created as a part of process of red cell hemolysis. Classification. So there are extrinsic abnormalities and also intrinsic abnormalities. Let's see the extrinsic abnormalities. First is antibody mediated, which can be immune hemolytic anemias, and it further classified into autoimmune, isoimmune and drug-induced hemolytic anemias. Autoimmune is further classified into warm antibody and cold antibody autoimmune hemolytic anemia. And the next causes are, it can be due to mechanical trauma, that is microangiopathic hemolytic anemia, due to cardiac reasons where they keep the prosthetic valves, and March hemoglobinuria. Direct toxic effects, which can be due to the infections like malaria, bacterial infection or other infections. The next cause would be due to the acquired red cell membrane abnormalities, that is paroxysmal nocturnal hemoglobinuria. And next is hypersplenism. Abnormalities intrinsic to RBCs. Abnormals of red cell membrane. Hereditary spherocytosis, hereditary elliptocytosis, hereditary stomatocytosis. And the disorders of red cell interior are disorders of hemoglobin, that is hemoglobinopathies. Quantitative disorders are thalassemia, which has reduced globin chain, and qualitative are sickle syndromes, hemoglobin D, E or C disease, that is structurally abnormal hemoglobins. Red cell enzyme defects, that is enzymopathies. Defects in hexose monophosphate shunt, that is glucose 6-phosphate dehydrogenase deficiency. Defects in Embden-Meyerhof or glycolytic pathway, that is pyruvate kinase deficiency. And this is a flow chart of the same. Now let's go to the pathogenesis. Pathogenesis is the red cell destruction. As we told earlier, it can be extravascular or intravascular. The physiological destruction of senescent red cells takes place within the macrophages, which are abundant in spleen, liver and bone marrow. This process appears to be triggered by age-dependent changes in red cell surface proteins, which lead to their recognition and phagocytosis. The red cell destruction occurs by two mechanisms, that is extravascular and intravascular. The extravascular, the site of destruction is mainly spleen, and the major mechanism of red cell hemolysis. Red cells are taken up by the cells of reticuloendothelial system, where they are destroyed and digested. Intravascular, this is a minor pathway of red cell destruction, and red cells are destroyed in the circulation, releasing hemoglobin. And this is the process of extravascular hemolysis. First, there is a senescent red cells which is phagocytosed by reticuloendothelial cells of spleen, and then it is and then the hemoglobin is released and broken down. Then the heme combines with globin, and the iron plus porphyrin is converted to biliverdin and bilirubin, that is unconjugated bilirubin. The conjugated it gets conjugated in the liver. Next, the bilirubin glucuronide excreted in the bile and acted upon the bacterial enzymes in the intestine, resulting in urobilinogen or stercobilinogen. And then it is again it get absorbed in the enterohepatic circulation, released in the kidney and resulting in urobilinogen in urine, or it can excreted in the feces in the form of stercobilinogen. This is the process of extravascular hemolysis. This is the same of the above. Destruction of RBCs, heme, the RBC it's broken down, heme it's coming delivered in bilirubin. Bilirubin then combines with the free albumin and forming a complex, and then unconjugated bilin it's conjugated in the liver, and urobilinogen is excreted in the and urobilin and other compounds excreted in the feces, that is stercobilinogen. And coming to intravascular hemolysis, red cells in the circulation that gets lysed in the circulation, and then coming to hemoglobin in the plasma, hemoglobin in the urine, resulting in hemoglobinuria, which is resulting in positive benzidine test. This hemoglobin, which is free in the plasma, it can be combined with the haptoglobin and resulting in hemoglobinemia. Okay, hemoglobin which can be absorbed by the kidney by the through tubular cells, and hemoglobin converted to hemosiderin tubular cells in few days, and then the tubular cell sheds off it, resulting in hemosideриnuria. So hemoglobinuria, hemosideриnuria are the features of haptoglobinemia, are the features of intravascular hemolysis. This is the same of the above. Again I repeat, intravascular hemolysis, free hemoglobin in plasma, haptoglobin, filtration of free hemoglobin by glomeruli resulting in hemoglobinuria, hemosideриnuria, and heme, the free heme combines with metheme and albumin forming methemaalbuminemia, albumin. And here the hemoglobin haptoglobin complex, which is low or absent haptoglobin in the plasma, that is why it is getting excreted, and it is metabolized in the liver to bilirubin. What are the clinical presentation of hemolytic anemia? There is pallor of the mucous membrane, which can be judged from tongue, pallors of the tongue. There is fluctuating jaundice. In some patient, bilirubin will be very high and may need blood transfusion exchange. Urine shows no bilirubin, but there is presence of urobilinogen. Gallstones are common in these patients. Patients with sickle cell disease may develop ulcers around the ankle. Aplastic crisis may be seen in these patients. Rarely, folate deficiency cause aplastic crisis. Peripheral blood smear findings. It determines the etiology of hemolysis. The evidence of intravascular hemolysis in the peripheral smear are red cell fragmentation. That is, the RBCs are not intact in shape. It is fragmented. Example, cystiocytes, helmet cells, where the evidence of extravascular hemolysis indicates presence of spirocytes in the peripheral blood smear. Polychromasia and presence of nucleated RBCs are indicators of increased erythropoiesis. Why there is increased erythropoiesis? When there is reduced or senescent RBCs or RBC destruction, kidney tries to produce the hormone erythropoietin to compensate the loss, and there is increased erythropoiesis. And this is the picture of the first picture. The first picture shows the cystiocytes. This is a target cell, cystiocytes, fragmented cells. Few cells are microcytic, elongated, and other cells. This picture shows target cells, and the few cells are fragmented, and the nucleated RBCs are seen. And here there is, the first picture shows polychromatophils. The second picture shows nucleated RBCs. How reticulocytosis is there? As told earlier, there is hemolysis in the bone marrow, which leads to erythroid hyperplasia to compensate the loss, and there is so much of immature RBCs which gets into the circulation, that is reticulocyte, and increase in count of reticulocytes resulting in reticulocytosis. Reticulocytes are nothing but immature RBCs which has remnants of RNA material. The reticulocytosis in the smear leading to polychromatophils, and then hemolysis leading to reticulocytosis. This is the process of reticulocytosis clinically. And this is a picture of reticulocyte. We have a remnant material in the RBCs. Laboratory evaluation of hemolysis, that is the feature of extravascular and intravascular. Hematological features like routine blood flow, we have polychromatophilia in both the cases. Reticulocyte count is increased in both type of hemolysis. Bone marrow shows erythroid hyperplasia in both the cases. In plasma or serum, bilirubin, unconjugated bilirubin is there in both. Haptoglobin is reduced or absent in extravascular, whereas absent in intravascular. Plasma hemoglobin is normal or increased in extravascular. It is highly increased in intravascular. Lactate dehydrogenase is increased in extravascular and more increased in intravascular. Urine has positivity towards bilirubin in both type of hemolysis. Hemosiderin and hemoglobinuria is present in intravascular hemolysis. Thank you.